Okay, and welcome. This is a replay of the February 26th webinar, which the video wasn't doing so well. So we're redoing that, and so what you're seeing is, I know those of you who are on YouTube, you're getting a day late, but okay, here we are. So today we're going to talk about the planning and discussing the full arch case. There'll be a number of things that we're going to approach in that, and but let's talk about a couple of other things first, okay? So let's talk about models. You know, those of us who are doing full arch cases have to show that we're doing full arch cases. People want to see what a full arch case is all about. They want to see, we call it solid bite, they want to see this. Okay, they want to see this. They want to see that you can't pull it out, that this is an all ceramic restoration. Yeah, there we go. So let me see how close we can get to the camera. Stay in focus. Hey, not bad. That's a new camera. Okay, so they want to see that. And that's the way you're going to be able to present that. About 9-10 years ago, I got veneers. Before I used to have spaces between my teeth. My consultant at the time said, why do you get veneers? I said, I don't need them. I don't want them. He said, once you get them, it's going to make a difference. What do you think I do when people want to say, what's a veneer? I go. So all of this is important. I'm not saying you should take your teeth out and put in dental implants. No, that's not the idea. But you need to be able to get this model made. Now, this model is not made by the conventional model manufacturers, the people who sell models. We actually went to our lab and had our lab make this up for us. Okay, it's all ceramic. It's the real prosthesis. It's a real milled zirconium prosthesis embedded in a plastic model. If our lab could do it, I'm sure your lab can do it too. Okay, it costs a lot more than a conventional demonstration model, but important. Now, you have people and patients who are going to have teeth taken out. Well, if they don't know what a denture is, show them. Give them an opportunity of seeing a denture. Say, this is the way it works. It's got a full palate. And it acts like a suction cup. So it acts like it covers the roof of the mouth. And so when you put your tongue up to the roof of the mouth, you're going to feel all of this plastic. One of the biggest complaints we have, there's two. One is they don't stay up very well, but many do. And if you have a good horseshoe-shaped ridge, we're going to look at that when we do the examination. I'll be able to tell you what your chance is of having a denture that's going to be retentive, that's going to stay in. If the ridge is flat, then it's going to move back and forth. It's not going to stay up nearly as well, and will displace for chewing forces and things like that. If you've got a good horseshoe shape to the roof of the mouth, it may be good. In fact, it may be good enough. Am I selling dental implants at that point? I want the patient to know what the options are. And a denture is a legitimate option. An upper denture is a legitimate option. Yes, there are downside risks to that, and once you go through the CAT scan and you show if the bone is thick, if the alveolar bone is thick, that's not going to resorb that fast. If the bone is very thin, so in some edentulous areas, let's assume the patient has 3 and missing 4 and 5, and then has number 6. I'm putting it the wrong side, but you get the idea. And you see that the bone is real thin in 4 and 5, then you've got to tell them it looks like you're going to be a very thin bone case, and you're going to be more likely to get bone resorption. You get bone resorption, these dentures don't stay up very well. There may be a real good idea, almost essential, that you get dental implants done, and get dental implants done at the time that you have the extractions done. Okay, so all of those things are storytelling. Remember, we've talked about storytelling before and how important that is. But people want to know a middle ground. Okay, so what about the middle ground? So here's what a lower denture would be. Okay, see, it's hollowed out. This is where the tongue goes. Notice how small the lower denture is. You know, you move your tongue, you move your lips, and this denture is going to go up and down. It's going to flop up and down. Now, there is a way of putting dental implants in so you can help retain that denture better. Okay, food is still going to get collect underneath it. It will. But at least the denture won't fly out of the mouth. And you'll get more chewing function because this isn't going to move. Is it as good as the one that's totally fixed, screwed in place? No, not even close. And by the way, most of our patients get the fixed. They do. I bet you 90% of our patients, maybe more, get fixed. So, but if if budget is that much of a problem, you're still going to pay a good deal of money for this. But if that's all you can do, then that's all you do. And by doing that, and by having models in front of the patient can, here, hold it, take it, try to snap it, get the idea of what this is about. Okay, give it to them, let them feel the prosthesis. Then they start to identify more with what's there and what can be done and how you're helping them. Now, as we go through this new topic, we're going to talk about letter writing. I know letters are a pain in the neck. Oh, I know we're trying to avoid it. We're trying to do anything we can to do other kinds of communication. Snail mail works. Snail mail works. Why do you think we send out 5,000 magazines every single week? Because snail mail works. And a letter works even better. But let's talk about a particular type of letter. Let's assume that a patient has a medical problem. I can take my phone on my smart recorder app, dictate a note, dictate a letter right there to the doctor. Dear doctor, patient X is going to is seeing us for extractions and for dental implants or for periodontal treatment. She had a blood pressure of 200 over 120 today. She says that only happens in the dental office, so likely we're going to sedate her. Could you give me a history and physical and make any recommendations you might? Thanks for your help. Sincerely, yours, Lee and Sheldon MD. Okay, what happens? That letter is going out on my letterhead. It's going to a doctor. The patient hears me collaborating with the doctor, so now the patient doesn't have to worry about asking the doctor. She knows or he knows that I've already communicated with the doctor and I've sent a letter. What does the doctor know? That I do periodontal therapy and dental implants. I do that with chiropractors. I do that with physical therapists. I do that with medical doctors. I do that. I've done that with acupuncturists. I've done that whenever there's an opportunity to communicate. Not a frivolous opportunity, but an opportunity to communicate and let the person know that, in fact, I'm interested in that person's health and what that person is doing for my patient, because it's our patient. The patient appreciates it, and if we're talking about public relations or perhaps even a little bit of marketing here, you're letting the doctor know that you care, and you're letting the doctor know who you are and what you do. And that translates into referrals. Will you get a referral directly from that doctor? Maybe, maybe not. But perhaps that doctor has a relative, or that doctor can then talk with the patient about his or her experiences, because now the doctor knows who I am. It's a good public relations effort. And so rather than shy away from communication or trying to make communication as electronic as possible, as digital as possible, well, that may be useful in a digital age. It may very well be. But that piece of paper in front of somebody still has an awful lot of power. Direct mail marketing does work. And as rare as it's becoming, to have a real letter in front of a real person, no fax, no PDF, no download and print, something that's on real letterhead, it's a rarity. And we want to be rare, don't we? We don't want to be like everybody else. Do you? No, of course not. Okay. People want to know how we get these patients. Of course, we get these patients through the marketings that we talked about. Okay, so it's Gilead Dental Marketing is our primary marketing group. We also use Ace Chat. Ace Chat is on our website. Just go to our website. You can see what we're doing for digital marketing, or you want to type in periodontist Melbourne, Florida, or dentist Melbourne, Florida. You can see what Gilead does for us. And Ace Chat collaborates with us, and they allow the patient to communicate with somebody. Perhaps they don't want to call our office. They just want to communicate with somebody. So they communicate with Ace Chat, who knows what we do, because they ask us a whole lot of questions, and then they have a database, and they know what kind of an answer to give for each of the questions that might come up. up, and that training continues as they chat and we get to know each other. We've been using chat for I think 8-9 years. Fabulous, fabulous, fabulous organization. So that's good. Finally, we're talking about staged therapies today. You know, anybody can respond to the commercial and go in and have all the teeth taken out, put implants in, and put a fixed prosthesis in all in the same day, because you see that in the commercials. But you also know that for the most part, we're periodontists in this group. And if we're periodontists, we should be able to do the same thing as the implant people do. But if we're differentiating, we save teeth. I'm going to write an essay, you'll get it this week, on saving teeth. Those of you who are on AAP Connect, you'll see it there. A letter that goes out to each patient or to anybody. 300-word essay on why you should see a periodontist. Because periodontists can save teeth. And we're talking about an example of saving teeth today. And you're going to argue with me? Oh, you're going to have a heart attack. You're going to say, oh, what's he talking about now? He's radical, man. Okay. So anyway, let's get to the lecture and let's move forward and let's see how this new system is going to work today. So we thank the Oral Reconstruction Foundation, as always, Allison Davis. Great at sending out continuing education credit, and you get it on Monday or Tuesday following the lecture. And thank you, Allison, for everything you're doing. Okay, those who want to come on, go to directoryofdentistry.com. If you know somebody who wants to come on, go to directoryofdentistry.com to get on the mailing list. Just go here. Please sign me up for the free material. As soon as you sign up for the free material, you're going to get notification of these webinars. And we're doing it on Sunday and Thursday. I think when I go to Thursday, there's just too many emails coming out. So those of you already know that we're doing something on hang on, let me get back to me for a second. You already know that we're doing something on every Friday. By the way, March 18th is a Thursday. We're doing an evening presentation for Dr. Ajay Satia it's in Southern California, Orange County, Mission what? I forgot. Anyway, we're going to do one for his study club, and everybody's going to be invited to that. So we won't be doing one Friday, March 19th. That'll be Thursday, March 18th. It'll be at 9 p.m. Eastern, 6 p.m. Pacific. And the lecture will be challenging. We're going to talk about the complete examination. We're also going to go over a case. It may even be this case, by the way. So if you think you're going to see another case, you may be seeing this case again. But we're going to talk about the complete examination, which is probably going to be more than half of it. And we're going to go over each step on video as to how we do the complete examination. You can come on. You can invite your referrers to come on, so you can see an example of a complete evaluation of why somebody should be coming to your office for examination. Okay, so let's go into this case, and this is a case that came in. This is one who came in. I forgot. We'll find out in a moment. Okay, so let's take a look at this. Okay, so the intake call comes in from Jennifer, and the intake call says, referred by patient of record. Patient has an upper tooth that broke. It's part of her bridge. She's sure she has other things going on in her mouth, and she's scheduled on February 22nd. Okay, so it was just last week. Okay, I make the doctor call. She says she has lots of work that she's put off because of the money, and she was referred by her daughter-in-law, who is a patient in our office. Patient arrives, and the assistant notes say that the patient presents today to see what options she has for treatment. The patient is aware that she is in need of a lot of dental treatment and was waiting due to her financial situation. Okay, so remember we talked about the blood pressure, 209/120, pulse is 73. Patient says her blood pressure is normally lower and goes up when she's in the dental chair. Okay, so we've already got that covered. Now at that point, when I see that, it's going to be, I'm sending a letter to the doctor in front of the patient. Oh, it impresses the patient so much. It just does. It makes a difference. Okay, so we go through the examinations. The examination head and neck is okay. Hang on, did I just lose something here? I believe I did. maybe not. Okay, so let's take a look at the photographs of this patient. So this is the photograph you saw earlier, and now we take a look, and that's her bridge work. You see ponics are the way the ponics are. I don't have an argument with the way the ponics were done. Sometimes you just have to do that, and she's a low lip line case. That's fine. So now we look at the lateral incisors view, and you'll see more in the x-rays. So there she is. Let's take a look at the occlusal view for a moment, and you'll see now on tooth number 6 right there, look at what's going on there. The bridge has a very casual relationship with number 6. Look at number 21. And you know, 21 is important because at that point I can say to the patient, let me go on camera for a second. I can say to the patient this. You know, one of the problems you have is that you're missing so many teeth. And we tend to lose our back teeth because they don't show. But you know what? Our muscles here are exactly the same. And so when we chew, or when we bite, or when we clench, you have the same muscular force on each side. But when you extract a tooth, and another tooth, and then another tooth, then only one tooth is absorbing all the muscular force that those 3 other teeth were taking. That's why this tooth broke. And so we're seeing your bridge work on the upper arch is breaking for the same reason. Very few teeth to take all that force. Communicates. Let's continue with the photographs. Are there any more photographs here? No, just this one. Okay, let's go forward. Okay, so here's just a capture of the CT scan as a Panorex. You'll get some ideas here, but it'll show up better in the PA, so I won't belabor it. So let's go to the PAs. Okay, so we look at the bridge, and so there we are on tooth number 6. And we see that the fixed bridge literally fractured from number 6. Okay, we look at number 11. There's a big infrabony defect. By the way, you know, that may not be a total infrabony defect. Maybe there's some attachment on that tooth. We'll talk a little bit about that later. That's where the controversy comes in. Periodontitis going on, number 12. Okay, there's tooth number 21. You see the evidence of the fracture. There's 21 again. Okay, now look at 25. 25 looks like it has a blown out, and it doesn't look like it. It has a blown out abscess. We'll talk more about that later. Okay, you've got a class 3 furcation here. Let's stop at the class 3 furcation because I just want to discuss this for a second. And this is for the restorative dentists here, because periodontists already know this. Somebody told you that a class 3 furcation is the end of a tooth. And if a tooth has a class 3 furcation, you might as well get the tooth taken out because you're going to lose more and more bone support. And when you lose more and more bone support, then what's going to happen? Yeah, the tooth is going to be lost. And you're going to lose so much bone support that you won't be able to put an implant in. Do you know what? That is total poppycock. Whoever told you that didn't know what he or she was talking about. Unless the patient has very thin bone in the posterior mandible, which most people don't, nothing like that is going to happen. And I've had teeth like this in my practice. I've been a periodontist for over 40 years. I've seen teeth like this survive for 40 years. Now, it may not survive in year 41, but don't extract a tooth like this. There's no need to. Let's assume the lesion is progressing. Let's assume that we don't get control of the periodontal disease, but we do. But let's assume that we don't get control of the periodontal disease. Well, what do we do then? Okay. Then if we can't get control, then maybe we have to extract the tooth. But there are going to be an awful lot of things I'm going to do first. I'm certainly going to culture the area or do an oral DNA test to find out what bacteria is growing down there. Because just like we have uncontrollable bacterial infections that we use that are controlled by antibiotics, that can occur here too. It isn't just root planing. Why do you think periodontal pockets get deeper and deeper, sometimes within your own practice, general dentists? And the reason is that all you're doing is paying attention to the root. Sometimes you'll completely instrument the root. And sometimes you won't. Sometimes the hygienist won't. Okay, they can't reach it. Curette only goes down, or you can only go down by feel 4 millimeters. That's the best hygienist. Can go 4 millimeters below the gum line and clean the root surface. Beyond that, it's crapshoot. But the other side of it is there are many diseases that are non-calculus diseases that have bacteria there, and that bacteria the toxins may have soaked into the root, and so we have to do root planing. We also have to kill the bacteria within the tissue itself, and we have to know what that bacteria is, and so we run the oral DNA test to find out what that bacteria is in order to be able to get that bacteria under control. Okay, now I know it's not just antibiotics. There are laser therapies that perhaps could help that. I don't know. We have a laser, and we have a laser that will do that, but we've been so successful in non-surgical therapy that we don't use the laser for periodontal disease, at least not very often. There's some evidence that you can use ozone, and ozone may very well take care of it. But understand, it's more than just what the hygienist is doing, and the hygienist has limitations and can only feel down 4 millimeters. That's why we use the periscope, because the periscope, I got a camera which will go down farther, and the hygienist can see down 6, 7, 8, 9 millimeters, and a good hygienist can then instrument that root and clean it. That's why we use it. Okay? Let's move on. Okay. So we look at the periodontal chart, and I want you to take a look at number 25, because 25 is the area where you had the blown out, remember the blown out apical. And on the distal lingual, it's a 9 millimeter pocket. So you see the 9 right there, right? Okay. So, but over here, it's 5, 5, 6. Now, I could have been chicken on the facial, and I just maybe didn't probe because it was hurting. So let's assume that goes to the apex too. Do you know what I key in on? The 2 and the 3 right here. That 2 and the 3 were non-inflamed, and there's attachment there. And that means there's something we can build to. Oh, I know you're saying that tooth needs to come out. And it might. But until we treat it, how do we know? We'll talk about that more in treatment planning in a second. Okay? So, all right, Cystic Node Angles Class 1, Fremitus. There's no Fremitus because everything was loose anyway on the upper arch. How could I tell if there was Fremitus? Overbite's 10%, overjet is 0. Crossbite wasn't there. I said the lip line is slightly high. I may be wrong. Can't talk about bruxism because I really couldn't tell, and the patient couldn't tell either. Most patients don't know they brux, as you know. Attrition is light. Affraction, no. Erosion, no. TMJ was okay. Maximum opening is 48 millimeters. Mallampati score was 4. Palatal vault is slightly flat. Why is that slightly flat important? Slightly flat is important very simply because you want to be able to tell the patient, hey, your vault is slightly flat, and so therefore this denture may move around a little bit. Just want you to know that in advance. So it's not totally flat. It's only slightly flat. So that's fine. Gingiva's firm. Okay, and bleeding lower anterior is heavy. That was coming from number 25. That was probably where I was probing into that distal lingual aspect, maybe even the facial. Calculus is moderate and plaque is light. Okay, so let's take a look at the CT, and we'll take a look at this area right here a little bit more, this number 25 area, which is pretty important. Now, what am I going to tell this patient? First of all, I'm going to tell the patient that the tuberosity, we're looking at the upper right side now, and the left side is the facial, and so facial is here, lingual is here, and I won't say that, I'll say the cheek and the tongue. But you've got good bone there. I'm going to tell you that bone often isn't very dense, though. So you've got good thickness of bone, and most people don't have that. Most people, you see this black area, this area is their sinus. Most people have the sinus that goes very low. You don't. You're very fortunate. Now we come into this area here, and now we're just behind your first tooth on the upper right side. And we take a look at this, and the bone, we measure that bone, it's 3.79 millimeters. We need 5.5 millimeters width of bone in order to be able to place an implant. So that's 3.79. So that's a place we wouldn't put an implant. Now we take a look at your canine tooth, but now we go beyond that, and let's look at how thin that ridge is. And I want to show you something that's important about this. This is for those of us who are treatment planning this. So now I'm going off the track so that I can talk to you. Take a look at where the facial aspect of the pontic is in the number, 8 area? And take a look at where the bone is. There's a significant overjet there. Now that's going to happen, let me stop this for a second. That's going to happen for a number of people where you may say, oh, the best bone is in the anterior, because if I look right here, I could put an implant right there, so could you. But the implant is going to emerge here. What's the distance? And I can't measure it while I'm broadcasting, but you can see. Put the implant here, or even put the implant in an angle here where it emerges here. Look at the overjet that's going to be present. So now you've got an implant here, you've got a pontic here. How's the patient going to take care of that? They can't. And so in a case where there's such a significant ridge discrepancy, or a ridge incisal edge or incisal profile discrepancy, where that is, I don't want to put implants that are lined up in that area. I don't want to put an implant in the anterior. I might be forced to, but that may force me to change my prosthetic design, and I might have to do a bar removable design rather than a fixed design in order to be able to allow the patient to take care of it and take care of it properly. Let's go on. Okay, so now number 11, and take a look at that. It's totally blown out, just totally blown out. Okay, 12, we've got something. Back to 11, now we're at 12, and now we're 13. So we look at 13, and there's good bone there. Okay, that's great. So I like that. Don't you? Okay, that's actually a good bone case, except I don't have anything anterior to number 12. And do I want to put my last implant number 6 and then go all the way to number 12 and make a fixed prosthesis? I don't want to do that. I don't want to do that. I don't want all of those cantilever teeth. Okay, we're coming up in tooth number 25, my favorite tooth in the whole mouth. There's number 25. Now, I want you to look here. You can get the idea that there was some facial bone. There may not be now. There is some lingual bone. How do we know that? Because when I probed a 2 and a 3 on the mesiolingual of tooth number 25. You already know where I'm going with this. What you're going to say is he going to really try to save that tooth? And the answer is, I don't know. That's up to the patient. What I want to do is give the patient the opportunity to save the tooth. And the patient takes the risk. Talk about it more. Oops. Did I lose it? Yeah, I lost it. All right, let me see if I can go forward here and see if I can speed this up. All right, I'm not gonna go farther with this because unfortunately I can't. I didn't realize I can't stop it, but you get the idea. So let's take a look now at this representation. So this is the anatomized representation, and take a look at tooth number 25. You can all see it. But that isn't the consideration I want you to look at right now. This is the consideration I want you to look at. I want you to look at the anterior space once again, just so you have a better appreciation for that. And now we're going to look at it from the lateral viewpoint, okay? So what you're looking at right here, this is the area, let's say in the number 8 or 9 area. That's the bone. And now we're taking a look and we're seeing where the tooth is. What a discrepancy. That's a tremendous discrepancy. Now I know there's scatter and radiation and stuff like that, but you get the idea. So that's a big discrepancy there. Now, interestingly, for most patients, the canine teeth line up. Canine teeth are fine. It's the number 7, 8, 9, 10 that don't line up well. And so if we're trying to make it as easy as possible for the restorative dentist, you want to stay away from a 7, 8, 9, and 10 if you possibly can when the patient doesn't have, where the bone doesn't line up with the teeth, or is this far off. So we'll place implants numbers 4, 5, 6, 11, 12, 13, something like that, in order to be able to make a case like this work. Okay, what do we have in this one? Yeah, let's take the lateral view. And surgeons, when we're looking at this, we've got to look at it like a restorative dentist. And so we're looking at the platform of the number 3 implant, but look at the platform of the number 4 implant and that of the number 6 implant. The platforms need to line up as well as possible. Okay, and so we're going to see what happens here when we line up the platforms the way they need to be lined up. So now we've got great bone, but remember we've got a density problem in the posterior maxilla, and therefore if I've got this much bone, I want to use a wide-bodied implant. I do. We've got to make sure there's plenty of bone around it. Just don't put a wide-body implant to put in a wide-body implant. That doesn't work. But if we've got plenty of bone, we want to do that. The one limitation that you have is that when you're doing that, when you place a wide body implant, you gotta know that the multi-unit abutments you get in a wide body. You can't get, for many, or at least in the BioHorizons system, and I think the Nobel system as well, you can't get an angled multi-unit abutment. So that implant needs to be in straight if you're going to put in a 5 millimeter. If it's going to be off like this, then you go to the 4.6 in the BioHorizons system so you can get a multi-unit abutment that will make up for the angulation problem. Okay. So now we take a look at the number 4 implant, and I know I don't want to do a sinus lift either, but take a look at how close the platform is to the lower tooth. Now we've got to do an occlusal adjustment on tooth number 30. Okay, we've got to reduce the occlusal plane there because you have a reverse curve of SPE. But we also have to level out the platforms, and the goal being from the platform to the occlusal surface on a full arch prosthesis, you want that to be 15 millimeters. You want 15 millimeters of thickness there, or 15 millimeters of distance. And so, yeah, we'll have to do a sinus lift. We'll use a vertebra there, and that will allow us to do a very simple sinus lift procedure. Now, here we are in the number 11 area. I want number 11. I want the bone in number 11, don't you? So, if you want the bone and I want the bone, let's see if we can find a way of angling the implant so we can put an implant in on the same day. Can we? Well, maybe the tip of that implant will go into the apical portion of that bone. Maybe we can take a chance. I don't want to. Too much. Too critical. I don't want to do it. I don't want to do an immediate implant there on that day. Okay, what about tooth number 12? Same kind of platform problem. Notice we want our platforms to be even to make it easier for the restorative dentist. So I'm going to take this 10.5 and make it into a 9 millimeter. That'll help. And now we raise this up and do some alveolectomy. Now we're getting close. Where restorative dentists can work with that. Okay, and now we go to the number 14 or 15 implant, whatever that is. And the same consideration, but there's less bone on that side, so we're going to stay with a 4.6 implant there. Okay. Now, if we go there, we could put an angled implant in and not touch the sinus, which I frankly like to do, but that makes it difficult for the restorative dentist, so let's see what happens if we straighten that implant out. Okay, and maybe with a vertebra, we're going to have to do a slight puncture of maybe a millimeter, millimeter and a half in order to be able to elevate that. It's interesting that often you think you're going to do a sinus lift and you're not. But with a vertebra, that's pretty easy to do. Okay, now notice what I did in the 20 area. I put a number 19 implant in. Why? Because I want to save the patient some money. Okay? I can put a molar, or you can put a molar on a number 20 implant and take that one tooth and make it into 1.5 teeth. And for most patients, that's enough. So they don't have to spend the extra $5,000, whatever it costs, for another implant and another crown, an abutment and crown. Okay? So routinely, I'll treat the number 20 area that way, or the 29 area that way. And I say, listen, if you want another implant, I can always put another implant in later on. You just let me know if you have enough teeth. I just want to see. I think this is going to be enough for you. Patient appreciates that. Frankly, for most patients, it is enough. A handful of times, patients will come back and say, you know, remember you talked about that additional implant. I want that additional tooth. So it's happened, but does it happen very often? No. And do people get mad at me because I did less? No. There's sometimes the patients say, listen, I'm missing so many teeth. Please give me as many as you can, and I will. Or let's assume the patient is an angle class 2 case and had bicuspids extracted for ortho. So now the patient is deficient one more tooth, and the second molar is essentially in the first molar site. Well, in that case, number 20 is in the number 21 site. I'm going to make that into a molar, and there we've got to do 2 implants. Okay, so I'm talking about the angles class 1 case with the fully dentureless case. You're trying to look at the surface area or the amount of occlusal surface, if you will, that's going to be in contact. That's what we're looking for. That's what we're interested in. Okay, so here are the problems. Blood pressure was high today. Abscess on the upper arch. That's the one number 6. Huge overbite. Perio problem on number 24 is actually number 25. Abscess number 25. And this tooth is part of a fixed bridge, which is very interesting. And there's some periodontitis in the lower arch. It's primarily the class 3 FERCA that we were talking about before. Okay, so now I'm going over the sequence that I want to use. And the assistant is making notes on everything I say. Assistants, if you're watching this, don't sit, don't listen. Keep typing and typing and typing and typing and typing. As your doctor says something and as your patient says something, keep typing. The more you type, the better. The more information we have, the better. From a medical legal standpoint, if you found out the patient has said something or the patient has said something to you, you're writing that down. If the doctor is saying something, your idea is to learn treatment planning. That's what you're here for. Because you're here in order to be able to assist your doctor in delivering the care that the patient needs. And the way the patient's going to understand why the care is being done and how it's going to be done is from you, not from me. Okay, I'm trying to spend a half an hour in the chair during my examination. I'm trying to make it as friendly as possible. I want to give the patient the benefit of everything that I can. But am I going to answer all the questions? No. Does the patient have a lot of questions? Yeah. Who's the one who's going to answer the questions? You, assistant, or financial arrangements person. So you have to have a good understanding of what's going on here. And so as the doctor's doing the treatment plan, the doctor's going over the x-rays, we want you to learn what he's saying or she's saying as well. So it makes a lot more sense to you, so you can make a lot more sense to the patient. Okay, so this is what Joy is writing. PRF, that's plasma-rich and fibrin, or plasma-rich fibrin. You're extracting blood from the arm. Most of you know that. You may use other ways of providing growth factors, manufacture growth factors, biologics, that type of thing is fine. Extract all the upper teeth, 6 units. Many of you know that I charge based on a 1 unit equal a certain amount of money equal a certain amount of time. For me, 1 unit is 10 minutes. And we charge in 10-minute blocks. So if it's going to take me an hour to extract the teeth, that's going to be a 6-unit procedure. Okay, and it's based on the units, not based on the number of teeth. That's how that's how our fees develop. Okay, we're gonna have to do a bone graft number 6 area. That's gonna be additional 3 units. Bone graft number 11, 12, and 13. That's gonna be 3 units. We're gonna use a BioGuide membrane. Sorry about the spelling for BioGuide. Mineros. We'll use 2 cc's. It's corticocancellous bone for those who aren't familiar with BioHorizons brand, and then we'll deliver the immediate denture. Okay, so I've made up my mind. I'm delivering an immediate denture. Why? Because the number 11, I want that bone to fill in before we put an implant in. Besides that, the patient's already told me she's on a budget. And I say, fine. you'll have 6 months to try out a denture and find out whether that's going to be good enough for you, because we'll make an immediate denture. We'll reline it with CoSoft as we need to. You'll have the immediate denture. You can look at the immediate denture and see whether the immediate denture is something that you would like to make more permanent, or whether you want to go with dental implants. So for me, it gives me a time to make sure your bone is healed properly. We'll take another Panorex or another CT scan in 6 months. For you, you can determine whether you can stop with a denture or whether you want to go to dental implants. Okay, so we're waiting 6 months. 6 months is reevaluation with me and with Joy for financial arrangements to follow to determine if upper solid bite can be done. That's the fixed prosthesis, or an upper bar because we can't use number 11, or just stay in the upper denture. On the lower edge plan, difficulty is we are unsure of number 25. Right? You're unsure of 25? I know you're saying we'll extract number 25. Humor me. Number 25 may be able to be saved, right? When we see these heroic things that's advertised, or somebody writes an article in Journal of Perio, whatever it is, I can tell you there's a bunch of articles in Journal of Endo that will show that tooth could be saved. And if you've ever seen Rick Schwartz lecture, endodontist in San Antonio, if you haven't seen him lecture, find a lecture. I'm sure you can find one on the internet. He will show you teeth that can be saved. They can really be saved. Teeth like this. Are they all going to be saved? No, of course not. Okay, difficulty is we're unsure of number 25. If we cut the root, there will be a hole the patient can see. All right, so let's assume we do a root resection under the fixed bridge. Fixed bridge number 23 through 26 fits just fine. Okay, so I can resect number 25, smooth off the underside of it and make it into a smooth pontic. But there's going to be a difference. There's going to be a space between the tooth and the soft tissue, and the patient needs to know the food's going to get trapped in there. But the simplest way is to remove the root, no question about it. Okay, simplest way is to do that. Most predictable way is to do that. But is it possible number 25 can be saved? Can number 25 be saved? Remember, there is some bone there. This is a perioendo lesion. But all perioendo lesions like this are endo lesions. This isn't a perio lesion that's gone down to the apex. This is a blown out apex. This is not a periodontal problem. If you want to save the tooth, I'm talking to the patient now. If you want to save the tooth, you might be able to. I think there's probably less than a 50-50 chance you can save it. But if you do save it, it's not going to cost you any more money for perio. You know, we're going to do our periodontal procedures, which will be non-surgical perioscopy anyway. I'm not going to charge any more to do this one tooth. So it's going to cost you $1,000 for root canal to find out whether that tooth can be saved. And if it can be saved, you won't have that hole. And if it can't be saved, then we'll have to go back and we'll have to do the surgical procedure, which you were going to have done anyway. So the question is, do you want to spend $1,000 to find out whether it can be saved or not? You know what? Some patients will say yes and some people will say no. But it's not a 100% decision on my part. It's a decision on the patient's part. Because there is opportunity for regeneration there. There is. You have to become convinced of it. And some endodontists may need to be convinced of it as well. Because they have chosen to extract teeth. You can always extract a tooth. You can. But teeth are capable of healing. And if you get rid of the etiologic factors, you'll be surprised at how many teeth can be saved. How many teeth can be utilized. Same with aggressive periodontitis. You know what happens, aggressive periodontitis ends up in an oral surgeon's office. What's going to happen? Teeth are going to be extracted every single time. What happens if you have deep infrabony defects in your office? Antibiotics, perhaps culture. I'd recommend oral DNA, or they're similar. Use antibiotic, do root planing, and the bone will come back. And the pockets will go away. particularly on the non-mobile case. Well, if you extract the tooth, you never know the patient's ability to heal. But if you treat the infection, you get the opportunity to see what the patient's ability to heal is. And you enlist the patient and ask, I think you have a 60% chance, 70% chance, 50% chance, 90% chance, whatever that is. Do you want to take the risk with me? The patient will say, what would you do? I'd say, for what you're going to experience by wearing a denture or dental implants, let's talk about an aggressive case. I'd take the risk. It's going to be a $5,000 risk to do periodontal treatment. If you did dental implants, it's going to cost 5 times that much. Actually, 10 times that much if it's upper and lower. I'd take the risk. Could I be wrong? I could. I'd take the risk. I think if we do the oral DNA, we give you the right antibiotic, and our hygienists are expert at perioscopy, I think you've got a very good shot. That's not everybody. Most people, we know how good a shot. I'm talking about the bad case. Same with you endodontists. Okay? You don't want to see a root canal fail because it doesn't look good for you, particularly to the referral source. But if the referral source is saying, listen, I'm going to send you the best endodontist in town. Until we get the root canal done, I don't know how well that's going to heal. And frankly, the root canal specialist doesn't know that either. If you want to take a chance, it's going to cost X amount of dollars in order to be able to find out. That's how we get all of these fabulous cases in the literature. It's doctors and patients communicating together and the patient willing to take the risk. In medicine, patients are willing to take risks as well. I know we're concerned with the medical legal system and all that. I know all that. But particularly now, there are debates in every aspect of medicine right now with COVID-19. You know what the debates are, okay? And if you've looked at every side of the equation, you'll know that if you just follow the deep dive and the party line, you're going to do one thing. And then you look over here and you look at other approaches, or at least other ways of looking at this diagnosis. You'll see more than one approach. So it depends upon how broad a resource you want to or can be for the patient. It's going to determine whether you're going to fall into the category where I do. Okay, where I'm saying, let's give it a shot. Or to tell the patient, listen, you may waste $1,000 on this. And the patient says, I can't afford to waste $1,000. I say, good, let's cut off the root. Okay. Okay. So the choice will be endo number 25, root resection number 25. Number 20, we're going to put an implant with an abutment and a molar-sized crown. Number 21 is going to will be a build-up in a crown. And make sure that you're programming the build-up in a crown into this. I'm talking about specialists. Make sure you're looking at the entire restorative plan. We want the patient to hear the entire plan from one doctor. We do. I don't care whether it's a restorative doctor or it's the periodontist or prosthetist. I don't care who it is. But one doctor gives the entire plan. We don't want patients to go here for part of it and here for the other part of it. All we end up with is a confused patient going back and forth, hearing two different things from two different offices because they're not going to hear the same thing from both offices. It's just not. What's the chance that that's going to occur? So you've got to really, hone down the communication skills, find out how much a buildup costs, find out how much a crown costs, and just get that into the system so you're presenting the complete case. Or if it's how much is the peri going to cost? My orthodontist, I know how much my orthodontist charges for ortho. I do. So I'm programming that in when I'm sending the patient to the orthodontist. If we do orthodontic treatment, it's going to cost X, and we're going to add that onto the treatment plan. Okay. We're going to do 2 IP with DV. Okay, that's 2 hours of root planing with perioscopy. The original name of the perioscope was Dental View. So it became DV, and we didn't go with perioscope. It's DV. On the lower arch, only it doesn't matter when the endo is done. Okay? So now here are my notes. Number 1, endoconsult number 25, or root resection number 25. Number 2, on the lower, we're going to do a 2IP with DV. Okay, we're going to clean the root surfaces off. Number 3, the patient's going to need impression for an immediate denture. Number 4, because there's no posterior teeth, the patient may need upper wax rims or even upper and lower wax rims in order to be able to get a bite registration. So there's going to be a second visit there for bite registration. Next, we're going to do all of the surgery, and I want to do all the surgery at one time. I always did all the surgery at one time. When we were doing 4 quadrants of periodontal surgery, when that was in vogue, I was doing all 4 quadrants at one time. Nobody, well, I shouldn't say nobody. Very few people want to come back for surgery after surgery after surgery. Oh, we'll do the right quadrant here. We'll do the right quadrant and left quadrant. No. Just get it done, sedate the patient, do what you need to do, get the surgery done. And so if we're planning, if at all possible, get all the surgery done at one time. So here we're going to remove the upper fixed bridge, extract all the upper teeth because the denture is already made. We'll do the bone graft, number 11, 12, and 13, as well as number 6. And we'll use the membrane, Mineros, root resection number 25 under the bridge, place the implant number 20, and deliver the immediate denture. All of that's going to be done at one time, assuming the patient's going to have the root resection done number 20. Now, all the infections are gone. Everything's taken care of. Maybe the endo was done at number 25. Wait 6 or 8 weeks and then do a reevaluation. That's what an RPPM is. PM, preventive maintenance, root planing. RP is root planing, so it's a check after the root planing. We call it an RPPM. You call it whatever you want in your office. But wait sufficient time after the non-surgical procedures to see how the patient's doing. Okay? Then we'll uncover the implant. Number 20, we'll do an Ostel check. But torque test your implants. We use the Ostel. I don't think the Ostel is nearly as reliable as torque testing. So torque test your implants. You know if the doctor is going to place 35 Newton centimeters of force on the abutment screw in order to be able to get that in place. Then you test the implant at 35 Newton centimeters as well. Make sure it doesn't spin. The last thing you want is a spinner in the restorative dentist's office. What a bad day it is for the restorative dentist when that happens. So make sure that it's all taken care of in your office, that you know the restorative dentist has every opportunity for 100% success at the time it goes back. Okay, so now final impressions for the abutment of crown number 20 and the buildup in crown number 21. Okay, reevaluate 6 months after the extractions in the upper arch. Take a CT scan at that point. Do we charge the CT scan? No. I just want the patient back in so we can plan the next phase. Either we're going to go to a permanent upper denture or we're going to go into solid bite. So I want to know which way we're going. Don't make that a barrier. You don't charge for the... If you saw my figures, you'd say, all right, I understand where he's coming from. Because, if we start thinking... If you start spending or charging too much for diagnosis, you're going to lose a lot of patients. A lot of patients who would see you for treatment because they're willing to pay for treatment. They're not willing to pay for diagnosis. You see internists for diagnosis. You see us for treatment. And they're willing to pay for treatment. But you charge for this, the periapical, you charge for that, and all those types of things. Particularly when in the middle of the case. No. If you're going to do that, then program that into your entire fee so you're not nickel and diming the patient every time the patient comes in. It'll go a long way towards helping you. Perhaps increase your treatment acceptance. Okay? So anyway, reevaluation at 6 months after the extractions in the upper arch to determine if the patient is going to move forward with a complete upper denture or a solid bite. And the entire treatment is $18,245. Now that doesn't include solid bite in the upper. This is what it would cost through the permanent maxillary denture. Okay, we use Green Sky. If you're not using Green Sky for financing, just do it. Use Green Sky. Okay, and I know there are other companies out there. I won't mention their names. You all know them. If you haven't used Green Sky, use it. We found Green Sky to be far and away the easiest company to deal with at the lowest fees. Okay, the lowest fees off the top from you, with longer plans. So there are a lot of things you can do with Green Sky. We've been using Green Sky for it's almost 2 years, And good. Okay, patient has good credit, owns her own home, and so she couldn't get Green Sky, but she's going to look into getting a home equity loan. Hey, that's pretty good, huh? Home equity loans are good. Yeah. And so now the patient's going to return on March 4th for financial arrangements. At that time, the patient's going to decide what she wants to do with number 25. Okay. And that's pretty much it. So I hope you enjoyed this. I hope that was worthwhile for you. I will see you again next week with a brand new case. Thanks for joining us. Bye-bye.